welcome to our Heart Talks webinar. I'm Celina Gorre, the CEO of WomenHeart. And to those of you who are new to us, we're a patient-centered organization that provides support, education, and advocacy for women living with or at risk of heart disease. We're glad to have you all with us today to discuss heart disease and diabetes in women. As you'll learn from today's discussion, the two are linked. Having diabetes increases your risk of heart disease, and unfortunately, for Black women, Latinas, Native American women, and others, your risk is disproportionately higher. So we want to talk today about mitigating risk. What do women need to know to stay healthy as they can? As healthy as they can, sorry. And for those who are living with both conditions, we want to give you support. We hope that this next hour will be both educational and inspiring for you. We have WomenHeart champions who today will talk about managing their mental health and wellness and share what it means to thrive living with diabetes and heart disease, and talk about the work they do in educating their community. Before we start, I want to recognize No Diabetes by Heart, an initiative that WomenHeart is very proud to be a part of. Led by the American Heart Association and the American Diabetes Association, No Diabetes by Heart aims to reduce cardiovascular deaths, heart attacks, and strokes in people living with type 2 diabetes. So with that, I will introduce our first speaker, Dr. Sonia Henry. She's the Director of Echocardiography at Northwell in New York, one of WomenHeart's National Hospital Alliance members, and is also a part of the Katz Institute for Women's Health. Thank you for being here today to discuss this important topic. And Dr. Henry, I'll hand it over to you.
Great, thank you so much for that welcome. Thank you so much, Celina, for that warm welcome. And hello to all of you. And I'm happy to and honored really to speak today on this topic, this very important topic, heart disease and diabetes in women. We're really going to focus on understanding disparities, managing risk, and learning how to thrive. So the agenda today is really to briefly speak about heart disease and the risk factors in women, to kind of just reset and make sure we're all on the same page. We'll review the risk potency specifically with diabetes and heart disease, and review some statistics on diabetes and heart disease in African Americans and other high-risk races, Hispanics and ethnicities. We'll talk about just briefly the link between heart disease and diabetes. How does diabetes cause heart disease? What women can do to manage their diabetes, managing mental and emotional challenges that come along with the diabetes diagnosis and heart disease that comes with it, and how to thrive and live a full, healthy life with diabetes. So we'll get started. Again, just to remind us all while we're here, what the agenda for Women's Heart is that heart disease is the #1 killer of women. It does not discriminate. 1 in 3 women die from heart disease. Every 82nd, 1 woman dies from heart disease or stroke. 90% of women have at least one cardiac risk factor for developing heart disease, but only 20% of women believe that heart disease is her greatest health threat. And death in the age population that's young, 35 to 54, appears to be increasing by 1% per year, secondary to the obesity epidemic. So we definitely need to take a focus on our young women. I think it's important to just review the risk factors because many of these are unique to women. On the right side of the screen, you see the traditional risk factors that we are all familiar with: hypertension, diabetes, hyperlipidemia, smoking, obesity, inactivity, and family history. But I think it's very important to also understand and recognize that there are unique emerging risk factors for women, as well as novel risk factors that are only really affecting women, such as autoimmune disease, pregnancy-related complications, sleep apnea, menopause, depression. We're focusing on diabetes today, and so specifically, diabetes does confer 45% higher risk of ischemic heart disease or heart blockages. And of course, gestational diabetes is important to know. If you've had gestational diabetes, your risk of developing diabetes is fourfold higher than a patient without diabetes, without gestational diabetes. And you have a risk of 70% of these patients will develop diabetes in 30 years. So let's talk about risk potency. What is that? And essentially, how does it affect the heart? So these, again, are the risk, the diabetes traditional risk factors and some of the novel risk factors that I just mentioned, such as lupus and rheumatoid arthritis. And essentially, you see here on the left here, the prevalence between these risk factors and men. And you can see that certain risk factors are more prevalent in women, most of them, in fact, except smoking, right? And you can see certain ones do have more of a prevalence in women versus men. And we'll focus here on diabetes. When we look at the risk of heart disease, look at this, there's 3 arrows. The relative risk is much higher for diabetes than it is for men. So in simple terms, if a patient, a man versus a woman, has the same level of diabetes, the same level, the same, finger sticks, the same hemoglobin A1C, the cardiac risk for a woman is much higher than that for a man. And there's multiple reasons, including women have smaller vessels. But it's really important to know that women, with the same exact diabetes profile will have enhanced risk. And this is a nice summary of what I just said that shows for this in here, very simply in blue, women, and in gray, men. And this just shows that enhanced potency that I just mentioned to you about diabetes. That, again, let's just make it simple. A woman with the same hemoglobin A1C as compared to a man will have a higher cardiovascular risk. They'll have a higher incidence of heart failure, a higher risk for coronary heart disease or heart blockage, a higher risk for heart attacks, right? Myocardial infarction, and overall coronary mortality. So, just in summary, risk, diabetes is very potent for women. So let's talk about that link between heart disease and diabetes. So what it is that diabetes damages, it's really a high sugar state that damages the blood vessel lining and the nerves. And so we have a neuropathy, and we have vascular disease or heart blockages, kidney disease, and and all of the vasculature that is associated, vascular disease that's associated with diabetes. So that damage to the blood vessel, this is an example of a blood vessel here, a cartoon, causes the risk of developing more atherosclerosis or cholesterol plaque buildup. And this accelerated atherosclerosis is what causes heart blockages, cardiac symptom, vascular disease in your legs and your kidneys, et cetera, in your brain. And once you develop this end stage blockage, if you will, and complications of the diabetes, you're developing strokes and heart attacks and heart failure and renal disease and peripheral vascular disease in your legs, even sudden cardiac death. So that's why diabetes causes heart disease. Let's take a little deeper dive into the racial and ethnic disparities in heart disease. So we can see here on this trend from 1999 to 2017 from the CDC, that death rate for the death rate for heart disease is decreasing. So that's a great thing, right? It's decreasing for all races. But you can see that there is some disproportionate change here, if you will. The higher risk groups, Black, Hispanics, are still, and South Asians, are still at highest risk, and Black persons are at the highest risk. And when we further break that down and look additional data, we see that young middle-aged Black women are at highest risk. And in comparison to white women, Black women have more cardiac risk factors. They develop heart disease earlier and have a higher mortality rate. And, when we take a further look at the American Heart Association, their stats, we see that for cardiovascular disease, diabetes, and hypertension, when it's broken down by sex and race, we do see that it is higher, for example, specifically diabetes. Take a look at this example here, really much higher in Hispanics and the Black race. And so overall cardiovascular mortality is much higher. I was asked to speak a little bit more, focus about African Americans, so just a little bit more on that. And this also represents, stats for other minorities, Southeast Asians and Hispanics, similar trends, but they're twice as likely to have diabetes as non-Hispanic whites. Diabetes in African Americans are two to 4 times more likely to have heart disease or stroke than adults without it. 15% of African Americans have age 20 or older have diabetes. African Americans are less likely to be aware that they have diabetes. When we take a look at the Blacks and Hispanic populations, they do have poorer glycemic control. Higher blood sugars, high hemoglobin A1C, and that unfortunately does lead to complications such as visual complications, amputation, and end-stage renal disease. 4 times more likely to have visual impairment than other races, and 3.8 times more likely to have end-stage disease than other races. And when you look at the overall death rates in all races, it's 21%. For all races, that's for Blacks, 41% for males, 36% for females. So you see that there's a disproportionate effect to minority populations. But, I do want to end on a positive note that, it is reversible and treatable. Diabetes is treatable. We need to move forward with that. One thing I think it's very important to mention in really minority populations is that this disproportionate increase in cardiovascular disease as well as worse outcomes is not only due to risk factor prevalence or increased prevalence. It's also due to behavioral differences, right? Physical inactivity, a mistrust of healthcare providers. This was a diagram I myself and Dr. Merez worked together on for a chapter that we did in terms of disparities across the healthcare system. But I do want to highlight also there's social impacts as well, right? That impact, specifically, low socioeconomic states, environmental barriers, highest psychosocial stresses in these neighborhoods. Going through the list here, you can kind of run the gamut here and see that it's not just about risk factors, it's not just about behaviors, but these socioeconomic factors and social factors do play a huge role in increased cardiovascular disease and worse outcomes. These are the non-biological factors that we still need to keep on the table, still need to keep in the conversation of how to improve. And again, the good news is that 80% of heart disease is preventable. We can work on this together, right? With our physicians, with our teams, with our families, to really improve your diabetes and your risk for heart disease in the future. This is done with education, lifestyle changes, and really just to empower yourself to take control. So first, I think it's important to review diabetes symptoms. So if you're not diabetic, you should be aware that it can cause increased thirst, increased hunger, frequent urinations, unexplained weight loss, feeling fatigued, numbness in your hands and feet, as it does affect the nerves as well. A slow healing of cuts or bumps that you may have, dry, itchy skin, frequent, yeast infections. It's really important if you have symptoms of diabetes to definitely get a baseline cardiovascular risk assessment. And what that means is really focusing in with your physician to get an ideal cardiovascular, what's your ideal cardiovascular health? What's my total blood pressure? What's my cholesterol, my fasting blood pressure, sugar? If it's over 100, then that's, part of the diagnosis of diabetes. Body mass index less than 25 kilograms per meter squared, abstinence from smoking, making sure that we're exercising 150 minutes, and a healthy diet. This is where our goals should be, right? And we need to know our numbers. We need to know what our hemoglobin A1C is. We need to know what the goals are. So goal of less than 5.6 is considered normal. And really this is individualized based on your numbers, and it's a slow trend. You're not going from a hemoglobin A1C of 11 to 5 overnight, certainly, but there's a plan to do that. I think it's important to talk about denial. Denial is natural. I don't believe it. I don't believe the number. There must be some mistake. It's not, not me. One cookie won't hurt. That extra piece of cake won't add up to another, high hemoglobin A1C. The sore is going to heal itself. All these are forms of denial, and you have to understand. Hopefully, some of the stats that was presented and the risk potency, especially to women, is really, really important to take. If anything, the message today that diabetes is serious and will cause heart disease and poor outcomes. So you have to accept the diagnosis and take action. So how do you do that? You want to really, again, we're talking about thriving, right? We want to educate yourself, create a support team, enlist friends and family, let everyone know you have diabetes so that they're not putting cake and candy in front of your face, right? Sugars, and you want to enlist your friends and family to eat well together, right? Let's all be healthy together. You want to talk about meal plans, right? Grocery shopping, looking at labels, really important to look at the carbohydrates and the sugars and the fat contents. When we do eat out, what are the healthy choices that we can choose? Carb counting, thinking about, starting to think about your eyes and your kidneys. And the focus is really to focus on one or two goals at once. This is what a healthy plate looks like for a diabetic. And if you have concerns or questions or cultural concerns, sometimes that certainly is important, right? In our minority population, that, how can we make that carb or that rice or a substitute, how can we really make that protein healthier? And I think it's really important to enlist a nutritionist, especially when you're a diabetic, to refine your calories, to speak about cultural diets, to speak about carb counts. I think it's really important to know the schedule. What are we supposed to be doing as a diabetic? Really every day, checking your finger stick, foot checks, making sure you take your medications every 3 months, really making sure you're checking in with your physician to get your hemoglobin A1C. Every 6 months, a dental visit. 1 year, get your flu shots, your regular labs, your eye exam, podiatry, hearing. And vaccines are important, as we know now in this pandemic, pneumonia and hep shots. And, mental health is really important. I think it's important to, we'll talk about it in the next slide, but, also plan for emergencies. If you need to leave quickly, get a diabetic care kit. What's in there? Your name of your doctors, your medication, your needles, your syringe, an empty bottle for your syringes, right? And there's so much information on the web that really makes this, a little easier for you to really just manage. And I think this is one of the websites that I find helpful, cdc.org/diabetes managing. And I think, we talk about diabetes burnout, right? Tracking your sugar levels, dosing your insulin, planning the meals, counting your calories, your carbs. It's a lot to manage, and it can really make you feel run down, emotionally drained. And patients with diabetes really are at risk for depression and anxiety, up to 2 to 3 times more. So it's important to really take inventory of your emotions, reach out to those around you, be honest. And, if that's not enough, better yet, get a mental health provider that's going to help guide you through this emotional terrain. And really, the goal is to make you feel good about yourself. You got to feel mentally good to feel physically good. So it's a lot, to deal with, but stress management, mental health is very important. Keeping a positive attitude, making sure to find exercise time to exercise and laugh. And really, focusing on you, right? And it's important really, just in summary and wrapping things up here, for us to, understand the diagnosis, thrive with diabetes, use all of the resources available to you, one-on-one time, whenever it's given to you, right, with a diabetic educator. Don't just put it on your list and say, oh, I'll schedule that. Really invest the time in yourself. Talk to the nutritionist. It's available to you. It's covered. If there are cost issues, talk to your doctor, your pharmacist. There are programs out there to assist. Again, I can't underscore the mental health, component, because it's so much that's really thrown at you, all these follow-up visits. And it's really important to not shy away from mental health providers and really use all these resources. Diabetic support, social media is also great, right? Social media to ask questions. I belong to social media groups for physicians, and it's always so very helpful. of course, take your medication, right? Medications are so important to really control diabetes. And then really take those breaks to enjoy your little wins. If your hemoglobin A1C drops down, celebrate your wins, celebrate yourself. And really, I end with this slide that you have to really take really good care of yourself, because we're always taking care of others, our kids, our family, our husbands, our partners, everyone around us. You got to take care of yourself first to take, outstanding care of everyone else. So thank you so much for the time, and I will stop sharing here so we can have a conversation.
Thank you so much, Dr. Henry. That was a great presentation. I learned so much even just today, and in particular about the potency, sort of the risk, the increase in risk, which I didn't really fully appreciate, especially for women. For those of you on the webinar, if you have any questions, please feel free to put it in the chat. But in the meantime, as you're doing that, I'm going to bring in our champion and bring her into the conversation, and then we'll come back to Dr. Henry for some of your questions and a more sort of general dialogue. I'd like to now introduce Melissa Castro, who lives in Sinton, Texas, and has been a champion with WomenHeart for 3 years. Thanks a lot for being here, Melissa.
Thank you, Celina, for having me.
I'd like to just start with having you very briefly tell us your story about when you were diagnosed with diabetes and then with heart disease.
So I will be turning actually 55 next week, and I was diagnosed with diabetes at the age of 18. So I've been dealing with diabetes in my everyday life for 37 years. As far as heart disease, I was diagnosed at the age of 37. So in doing the math on that, last night it just hit me that I've been surviving heart disease for 18 years. So yes, so it's, and Dr. Henry, you did an amazing presentation. You hit so many points that are so important in order to be able to thrive with the condition of diabetes, and then of course the heart disease.
Melissa, before you were diagnosed at 37 with heart disease, did you know about this sort of increased risk based on the fact that you had been diagnosed with diabetes at 17?
Yes, I did. Unfortunately, my maternal grandfather passed away at 54 from an aneurysm. And so I believe he had been diagnosed. Now we know after going back that he actually had been diagnosed at the age of 19, but did nothing about it. So probably when I was in junior high was when he really was dealing with all the effects of having uncontrolled diabetes. So I saw him lose his eyesight. I saw him had to retire at an early age. I saw him, pass away from an aneurysm. So I saw it all. Him trying to modify his diet. And then as well, my dad had coronary heart disease. So as well, I was, I witnessed that. So I knew that it was something that it was going to ultimately be a part of my life.
Mm-hmm. Mm-hmm. And you talked about the steps that your granddad sort of took in trying to mitigate, right? Trying to mitigate that risk or manage his heart disease. Were you as a family also sort of doing it together, given that it sounds like you see this multi-generational risk?
Yes. And it was awakening. The way that I grew up, there was nothing that was hidden from us. I mean, we were right there as kids, seeing him with the struggle of my mom and his other daughter trying to manage his diet, just trying to modify that. I mean, this is a man that has eaten the same way for years. And then of course he also drank, and he was a heavy smoker. So I saw all that and him trying to modify the diet. But I think back then as well, it was the part to where you're basically having to deal with someone being told you can't do this anymore. And I think that's where the mental health plays a big part in just in the acceptance. But again, we're going back. I mean, I'm 54 right now. At my age, he was dealing with all that. And then when I reflect, he just seems so much older because he was so already being so affected by the diabetes. And so, I saw those chats. So it was always out there. And I saw him at that time, they didn't have the meters to test her sugar the way that we have now. So I saw my grandmother administering the, testing of the urine, the sugar, and, it'd be color coded. And she'd say, oh my God, you're doing so good. You're at a, at a yellow. But what does that say to us now? The urine was already coming out the sugar was already coming out in his urine. So we know that at that point, there were so many organs that were already being damaged by, the level of sugar.
Yeah. Yeah. And let's sort of talk about, in the last couple of years, and of course we're going to talk about how the pandemic has sort of affected not just your ability to manage your diabetes and heart disease, but obviously also the toll that's taken on our mental health, your mental health in particular, and well-being. Have you had to manage depression or anything to ensure that you're in an emotional state of being healthy to be able to manage your disease states?
That plays such a major part in Dr. Henry mentioned, when I had my first heart attack, thank God it was in a controlled setting at 37. So I actually had my heart attack while in the cath lab. So I did not have any major heart issues. And then I was young. And so when I went in, the cardiologist my cardiologist, because, he knew me and I was young and I was never offered to be placed on any kind of antidepressants. And now I really feel fortunate for that. So I never dealt with that. I think throughout my whole condition, as far as diabetes and the heart disease, I've never dealt with that until this pandemic. I lost a very close friend of mine. And so that it did. And then of course, I did work from home for about 2 months. And in the course, losing her to that, I did feel a sense, finally, I had that challenge, but you have to, one of the things Dr. Henry also mentioned is you have to not let it control you. I had to I said, I have to be more active. At that point, we were at home and so forth. And I just started, I've never been a runner, but of course we couldn't go to the gym. We couldn't do a lot of things. And so I started walking. And that in its sense is like, look, I'm able to do this.
Yeah.
She's no longer here. I have the choice whether I'm going to let this depression take over me or I'm going to do something that she can't do anymore. So that's kind of the mind frame you've got to put yourself. You can't pity yourself and you have to accept it. That I think is the reason why I thrive so much, because I've seen the ugliness of the conditions. And early on, I decided I don't want to lose any toes. I don't want to lose eyesight. I don't want to lose the ability to get up and not feel my feet. So that mental health is so important. Physical fitness is so important, because when you feel like, oh my gosh, no, you gotta just this is not going to rule my life.
Yeah. And Dr. Henry, I know that you really reinforced that point during your presentation about how mental health is really not just one of the risk factors, but potentially a way to thrive if you really pay attention to your mental health. Right. Can you talk a little about how adding the pandemic as another pressure on top of all of these things that our patients with multiple morbidities are dealing with, how that's really, in my view, really elevated mental health is a really important thing for all of us to watch out for.
Right. Yeah. No, for sure. Yeah. Definitely. Not only for diabetes, I think for heart disease in general. It really, I think, just I'll share a stat with you. In the beginning of the pandemic, the first few months, we did notice that secondary to fear of coming to the hospital, secondary to mental health disorder, patients were, staying at home. They weren't getting treated. And so there were, unfortunately, more cardiac arrests at home, and a high number of that, from the diabetic population as well. I think it's so important to highlight that the importance of taking stock of your state. You did a great job there, Melissa, in recognizing that. You have to be honest with yourself and, realize that you are in control, right? You're the CEO of your health, and you can, step outside like Melissa did and exercise. Exercise is a great treatment really of so many things, including cardiovascular disease, diabetes, and mental health, right? Because it does increase endorphins, it does increase cardiovascular reserve, it gives you positive feedback whether you've exercised that may prevent you from eating that cookie, right? So I mean, there's just so many benefits from just the exercise, not only mental health, but actually real impact on your physical health. So I think a lot of people did learn that in the pandemic, that the exercise was key to getting outdoors, walking with a friend, biking, running, learning how to run. I think, unfortunately, a lot of people did suffer, right, depression in this pandemic, and probably are still suffering from depression and isolation, lack of contact with friends, family, people you see regularly on a day-to-day basis. So if you are suffering from that, again, certainly reach out to your healthcare providers. There's also, I think, which was at least we use well in our institution, was the video health, right? The telechats and talking to your doctor. And I think if some people are in areas that are increasing because of the Delta variant, there is still that access, always access to physicians via video health and telehealth, and please, you shouldn't suffer. Certainly reach out for help if you need to.
Melissa, I was chuckling a little bit when you talked about you just started walking, because that's exactly what I did during this. I was like, I can put my shoes on and walk, right? Mm-hmm. Like that is the one thing I can do. And I love the idea that you weren't focusing on what you couldn't do, you're focusing on what you could do. And that's really powerful, I think, to take control, as you said. Dr. Henry, we have a question from Anne that says, how does age impact diabetes and heart disease? I've had diabetes for 52 years, also diagnosed at 18. I had few, if any, issues until a couple of years ago, and suddenly I had neuropathy, heart disease, and other issues.
Right. That's a great question, Ann. It's a problem that doesn't happen overnight. The effects of diabetes, it's not that you're diagnosed with diabetes and the next year you're in trouble. It's a progressive problem, unfortunately. So you have to. That's why. So to answer your question directly, it does take time to develop the heart disease. It takes uncontrolled, or even, again, hemoglobin A1C above 6.5. And I'm saying that because I know some of you are familiar with that. The sugar that's high, over time will poison the blood vessels. And, 10 years, 20 years is when you will develop kidney disease and vascular disease. And so that's why it's really important you have a window of period really to focus on maximizing those ideal cardiovascular risk numbers that I put on there. And really taking stock, really exercising, really getting those numbers controlled, because it's really not until 20 years that we're seeing the really bad problems that you develop. And I think that, it's important to micromanage diabetes. It's not something like, it's good enough, it's okay. You really want to micromanage by the decimal point, right? So we're going down to like, is it, did I get from 6 point, did I get from 8 to 7.8? You really kind of want to celebrate those wins, because, it's impossible to make these big jumps. It's impossible with diabetes. You have to kind of celebrate the minor wins. So the other part of the conversation, Anne, is that as you age, and you become postmenopausal, you do increase your risk for heart disease because of the loss of estrogen. So that, it's not just diabetes, it's also aging, it's also being postmenopausal. Everything gets hyper, unfortunately, as we age, it gets your risk, as we talked about in that first slide, heart disease is our number one risk. And as we age, it gets more prominent. So, even one thing I want to highlight to everyone listening, once you are diagnosed with diabetes, it's a cardiovascular equivalent. We treat you as if you have heart disease from day one. So that means that your cholesterol needs to be the same as if you've already had a heart attack. So that means your LDL should be like less than 100, all of you, if you have diabetes. Your bad cholesterol no longer, like a regular average person, we might let their cholesterol be 130, 140, even up to 160, your bad cholesterol. Once you're diagnosed with diabetes, your LDL has to be less than 100. And that's how you prevent heart disease. That's how you prevent kidney disease. You got to control the diabetes, the cholesterol, the hypertension. It becomes a whole master plan.
I'd also like to kind of add to that and echo what Dr. Henry was saying, is that I believe that because at such a young age, and it is, you do have to manage it that way at all times. And it's hard. The acceptance of the condition is going to be the first thing that you have to do. You know, I was 18 years old and there was, 3 years. When I was diagnosed, I was getting ready to go off to college out of town. That whole thing in itself is being on your own is life-changing. So not only did I have to manage that, but I had to manage, staying up late, going out, drinking, eating, it all, and I went through a series of, one of the best things that I think, and at that point it was my parents' decision, but I went, once I was diagnosed, I was under the care of an endocrinologist. So they're so much more aggressive in managing the condition. And I really want to stress that it is a condition because, like Dr. Henry said, it can be controlled and treated. Diabetes can. And so I believe that in doing that, I was on insulin. Back then they only had a regular, and they had, the slow dose medicine, insulins were just coming out. So it was a lot of testing medications, hit and misses, finding out what worked. But I think if anything is that you have to make sure your medical team is so important. Getting a doctor that you trust, that you can communicate with. And I think the most important thing, and this happens, I think, a lot when people are diagnosed at a later age, you have to be completely honest with them. When they ask you, how much do you drink? Do you smoke? You have to be, how much physical activity do you have? You have to be honest with them. I think a lot of times people are not successful with managing their diabetes if it's at an older age, because right away they say, well, you can't drink, you can't do this. No, you have to be realistic, first of all. And you have to decide, you're going to tell your doctor. I was fortunate enough that I didn't deal with high cholesterol, but they wanted to always maintain me, like you said, below the numbers at all times. Well, any kind of cholesterol medication, I would have really bad leg cramps. Well, my doctor kept going. Then you've got the challenge of the insurance companies. A lot of times they don't want to cover it. We've got some injectable cholesterol medication now that gives you no side effects, which I'm on now. And it's awesome because it took a lot, but the whole time I've been able to keep my A1C at below a 7. So once this is going to be my challenge, I compare it, if there's any gun owner, sorry, but that's the only thing I can think. Well, as someone who owns a gun, whether it's going to be for your family protection, it's going to be for your work, you maintain that weapon at all times because that's going to save your life if you're ever put in danger. Same thing with your heart and your body and everything. Every day you have to maintain it because I knew that ultimately I was going to have a heart episode. Because of the diabetes, I knew that was going to happen. So I had to maintain, okay, let's take this test. Where am I at? My heart attack, like I said, was in the cath lab. When I first went in that I felt bad to the ER, my endocrinologist said, there's no way you can be having a heart attack. We just did your results. You just did an EKG and it was normal. Yeah. And I kept saying, no, there's something wrong. There's something wrong. And when I went in, like I said, they found that I had a clogged artery. And I went in, and as a cardiologist is doing the angioplasty, and he's saying, relax, because you're having a heart attack. I sat there and looked over on the monitor, and I've never felt a chest pain in my whole life with heart disease, which again, the symptoms are so different for women. So in seeing all this, I've never been, okay, anything that doesn't feel right to me, I know my body better than anybody, and my doctors all know that. The hormonal issue with women, that so much affects your heart. From the moment that, as young girls, we go into puberty, whatever you decide, if you're going to put your daughter on any kind of birth control because you don't want to, deal with having an early pregnancy, well, you're stressing out her heart already. So you want to make sure and check that heart disease isn't in your family before you decide to do that to your daughter. There's just so many things that you can do. Your gynecologist, talk to them. Like I said, I saw everything with the condition that affected my family. So my medical team, I go get tested for all my metabolic lipids, everything, A1C, every 3 months. And so, 6 years ago, I went through a quadruple bypass and I was back to work in 3 weeks. And that was because of my physical activity level that I did. 6 years ago, I lost my younger brother at 44, who had also dealt with heart disease and diabetes, but just did not control it as he should have. So he was not successful and he succumbed to complications from the same surgery that I had months after his death. So I've seen actually how it happens, and that's what you have to do. It's so important. And there's one thing that Dr. Henry, the whole being diagnosed at a pre-diabetic level in the A1C, sometimes I think that it's hard. That's one of the things that I fight people on when they tell me, and I'm out trying to, give my life story and how I've been able to thrive with my conditions, is I don't accept that. You can't be pre-diabetic. It's almost like being pre-pregnant. Like you have to really don't take that as like, okay, I can manage it with my diet. Because what happens whenever people kind of like it gets downplayed to me, then they don't react because they don't feel that sugar increasing and them not feeling anything. And then before you know it, they go into the doctor and their A1C is at 13. What do you now let's get aggressive about it. But yet, if that's been over a course of 2 to 3 years, Dr. Henry, the damage that it's done to your organs. And that's when the renal disease and everything else it affects everything. So I think that it's super, super important, like I said, to be honest and to make sure that you're comfortable with your doctors.
Wow, that's a lot. And Melissa, it sounds to me like what I'm getting from you is that because it's been a multi-generational experience for you and your family, this combination of diabetes and heart disease, in some ways you've had those generations for you to learn the lessons, right? It's not just been in your lifetime, it's been in these, your family's lifetimes that has really contributed to your ability to better your understanding for what can happen and take control. The other point I want to take from what you said too is you want to think about your doctor as a partner.
Yes.
As a partner in your health. I've learned that lesson in my own health journey that, when you think about your doctor as a partner, then it changes the relationship where you feel empowered and you feel like you can ask questions and there's no stupid question, you need to be honest because then you get to much better answers.
Right.
I do want to ask you, Melissa, because I know a little bit about what you do in your community. I want to focus a little bit on how you've taken your experience. You've alluded a little bit to it already, but how you've taken your life experience to give back and educate your community, in particular the Latino community, and specifically with that focus of the higher rates of diabetes among the Latino population.
Well, as far as with my community, so I do work with a law enforcement agency. So at any time, and it is, it's a high stress environment. And a lot of times, and I take this from, with my own brother, he was a first responder, he was a fireman. And a lot of times because they fall into this career choice, they feel like they're invincible and they forget the little things. So a lot of times because they know of what I do, with the WomenHeart and the advocacy groups and so forth, then they'll reach out and well, this is what I felt. What was your experience or what do you think? And so I try to be a voice for them, as well as you know, these conversations come up all the time just because they know my history. And the first indication, you know, when you're 37 years old, you're in a cardiologist's office and they're like, what are you doing here? You're so young. You know, there's always, I think, there's almost like a certain way that you're supposed to look because you have coronary heart disease. And, you know, it affects everyone. And I surround myself with women that also advocate for other things. So as I mentioned before, you know, I've got friends that are in the community and they're like, hey, we would really love you, you know, women empowerment groups, you know, the empowerment is a big part of it, for me to be able to say, okay, I've had this challenge, but this is what I've done. Or I failed here, but I figured out how to succeed in this other, in changing, you know, it's all about modifications. So I do that, you know, as, you know, like I mentioned earlier, you know, I'm bilingual. So that helps a lot. You know, with the Hispanic community, I mean, it's so, you know, it's so prevalent in our community. And unfortunately, because of the cultural differences, just in the way that we were raised and things that we like to eat and how we were taught to cook, we can modify all those things. You know, one of the hardest things for me to give up was white rice because of the Spanish rice. And it's taken a lot of change to be able to, you know, use brown rice instead of white rice, but it makes a difference. So, you know, whenever I get a chance, I'm always there to try to help someone to change to where they don't feel like I'm not going to be able to do this for the rest of my life. Yes, you can.
Yeah. You're muted, Celina.
Thank you. We're sort of coming to the end here, but before we end, I wanted to give Dr. Henry and Melissa a chance to sort of offer some last perspectives, especially for women, again, facing both heart disease and diabetes, and in particular on how to thrive today in the context, you know, among, you know, in this pandemic. What are your sort of key tips, and in particular for women who may be just new to these diagnoses or this combination of diagnoses? Let's start with you, Dr. Henry, and then we'll come to Melissa.
Sure. I was just reading in the chat as well. I wanted to someone wrote a point here, and, you know, so I think, you know, just that we talked about the levels being controlled, and it takes years for these diagnoses to develop heart disease, getting quadruple bypass. There is, as we see in Melissa's case, you know, as I mentioned, 80% is controlled, but 20% there's a component of genetics, right? There are genes that are, you know, well, we found, you know, in African Americans, in Hispanic populations. So you can, unfortunately, you cannot erase the genetic component. But you know, Melissa, you know, has seen these complications from her grandfather, from her brother, and she's here thriving, right? So she's seen maybe some missteps and have learned. So you know, you may not be able to avoid, you know, heart disease, but you can live, and the whole point is that you can thrive. Right? You have to fight, and you have to maintain, and you can't give in despite a controlled number. If your number is controlled and your dysfunction is getting worse, we got to take it up a notch, you know, as your partner. We have to, you know, go deeper. We may need to switch you over to the injectables, and you have to sort of, again, have those conversations and be honest. You know, I have patients myself who develop heart blockages with a controlled hemoglobin A1C and an LDL of 70. And what do I say? I say to them, we have to go deeper. We got to get you even further controlled. We got you get your number down even a little bit more, because I've seen, I put a patient on Praluent, and they were maxed out on statins, and she still had a heart blockage. And now we have her LDL to 60. So again, the whole point is to continually engage with your physician as a partner that Celina mentioned. I think that's number one, right? And if you don't have a good relationship with your physician, and they're not following you, like Melissa said, every 3 months, then you need to find another physician. You know, you need to find another partner, right? You know, if the partnership's not working, you got to find another partner. One. Two, if you feel, if you're still, somebody mentioned they still developed heart disease, again, deeper dive. What are the other risk factors? Are there other risk factors that we're not covering? Are there other, I gave you that second slide with, I don't know, too many things on there, but a lot of risk factors exist. So we can't just ignore, the weight. We can't ignore the inactivity. We can't ignore the sleep apnea. We can't ignore the irritable bowel disease. Those are all forms of inflammation, right? Inflammation itself also affects blood vessel, coupled with diabetes, stress, anxiety. I talked to you about that last, that is huge in the younger population. Just getting medical, now a lot of cytokines and inflammatory markers will circulate, and then that coupled with diabetes, that's a problem. So it's not just, oh, my hemoglobin A1C is perfect, but let me deal with my anxiety, let me deal with my depression, let me deal with my IBS, because all those things will add to your outcome for heart disease. And I think that's a very important point for women to recognize, because those novel emerging risk factors, that's where the key lies: inflammation, controlling the other parts of your health as well. So I think the partnership, and also thinking about other things to make your health better. And then also, just lastly, just to underscore that mental health aspect, really. And then I think lastly, just one more point, a diary. Keep records, right? Write down your everything, really. Keep stock on yourself, keep ownership, whether it's counting your carbs. Start slow, start with one thing. Let's focus on the carb count, the calorie count. Let's focus on tracking the numbers. Keep a diabetic diary. And I think you'll see your progress, or you'll see where you kind of misstep, and then you need to kind of take stock and reassess and be honest. It's a truth teller. The diabetes is a truth teller, and I think it'll help you be honest with yourself. So I'll stop there.
Dr. Henry, over to you, Melissa.
Awesome. Yes, Dr. Henry, I mean, you're incredible in hitting all the points that need to be hit. And yes, you're so correct. Like I said, one of the most important things is I've had an amazing communication with my doctors, and and it's always in their honesty. My cardiologist, he's like, okay, you're doing good, keep doing this. And he'll say, you know what, I do see a little valve, and we'll probably have to deal with that in a couple of years. Everything that they've told me, we've gotten there together. And so getting ready for that, and knowledge, to me, being your own self-advocate, read, there's webinars. I mean, anything you can sign up that has anything to do with either one of these conditions, go look at it. It's a continual process right now. I've been blessed that I haven't really dealt with any kind of arthritis, but I've got a torn rotor shoulder that the doctor doesn't feel that I should get operated on. So right now I will avoid a lot of medications because one, they affect my heart. Two, I do not want to take anything or be on any kind of over the counter because my kidneys, I have to take care of my kidneys, I have to take care of my liver. So I keep reading. And you've mentioned the inflammation, and that's where I'm at right now, Dr. Henry. It's like, okay, I've got to tighten this up a little bit more. So now I'm looking into anti-inflammatory foods, changing my diet, because that is where the pain's coming from. So you have to constantly, you be your own advocate, and even when you go into the doctor, there's times that I say, okay, what about this? I read this, what about this? Okay, well, so knowledge is power. And as well, it keeps your mind occupied to where you don't have time to get depressed and feel like you're going to lose your battle. So yes.
Thank you so much. I feel so incredibly inspired by you, Dr. Henry, and all of the important information you've given. And also Melissa, just, you've really taken this on, and, just, I think, are so empowering in helping us think through that, like focusing on what we actually can do. And there is so much we can do.
Yes.
It's so much we can do. And just from my own perspective, I think, again, I want to emphasize and reemphasize the partnership with your healthcare provider, your physician. Like Dr. Henry says, if it's not working, find another. I had to go through that this year, and I'm so much happier with my new healthcare provider, because it is a partnership, and it's the first time I really thought about my physician as a partner in my health. So Thank you both. Just to say that a number of you have asked whether you can, whether we're going to have a recording of this webinar. We are, so it will be available immediately after. And we also have a new blog post at womenheart.org about this topic in particular. So there's lots of information about it. If you have any questions, please do come to us. We're here to support. And I would also say, just as a last emphasis on mental health, clearly what WomenHeart does, one of the most important things that WomenHeart does is provide peer support for women living with and at risk for heart disease. And this is a thriving community in and of itself, where you're going to meet women, fantastic women just like Melissa, who are here ready and willing and so excited and committed to helping those of you who need the support. So please do come to womenheart.org, find us, and come back for the next webinar that we hopefully will have soon. Thank you again, Dr. Henry. Thank you, Melissa, and thanks to all of you for joining us today.
Thank you. You have a great day.
Thanks, Melissa. Great job.
Thank you. Great job, everybody. Thanks.
Thank you.